Hello friends, today we are going to discuss about the hepatorenal syndrome. This was the question which was asked in DRNB exam in December 2022. So first we'll start with definition. So HRS, it was classified as HRS1 and HRS2 according to old definition. Now it is classified as HRS Aki and HRS Naki. So what is HRS acute kidney injury? It is rise in serum creatinine of more than 0.3 mg in 24 hours or at least 50% in 3 months. There is a no response after volume expansion with albumin of 1 gram per kg per day for 48 hours. There is a cirrhosis with ascites, absence of shock, no current or recent use of nephrotoxic drug, and absence of parenchymal disease, that is no proteinuria, no hematuria, and normal kidney function or normal kidney ultrasonography. Then HRS non-acute kidney injury is divided into HRS AKD, acute kidney disease, and HRS chronic kidney disease. So once the patient is diagnosed as AKI, it is eventually falling into category of the AKD because AKI is subunit of the subtype phenotype of the AKD. So all these AKI features, if they are lasted for more, if they are lasted for 3 months, then it is coming in the category of acute kidney disease. And if they are lasting for more than 3 months, then it is going into the category of HRS-CKD. So in patient with cirrhosis, according to the guidelines defining AKI, according to the KDIGO criteria. So just now we have seen it is increase in serum creatinine value of more than 0.3 mg per DL within 48 hours or at least more than 50% from baseline value known or presumed to have occurred within the prior 7 days, and urine output is less than 0.5 ml per kg for more than 6 hours. So in HRS with cirrhosis, we recommended defining AKD and CKD using the KDIGO criteria. In patient with cirrhosis, we recommended defining complete recovery from AKI as a return of serum creatinine to within 0.3 mg per DL of baseline has occurred. So what is the reference value of serum creatinine should be used to define AKI with cirrhosis? So it is recommended to use lowest stable serum creatinine value obtained in previous 3 months for diagnosis and staging of AKI. If no values are available in previous 3 months, then the most recent value up to 12 months prior may be used. So in the absence of known baseline serum creatinine, it is suggested to use lower of either serum creatinine on admission or serum creatinine back calculated from estimated GFR of 75 ml per minute per 173 meter square as reference. So what are the diagnostic criteria for AKI due to HRS? So HRS AKI is the phenotype of AKI that is specific to the patient with advanced cirrhosis and ascites. It may also occur in the presence of tubular injury, proteinuria, and pre-existing CKD. So the diagnostic criteria for HRS AKI is cirrhosis with ascites, any increase in serum creatinine of more than 0.3 mg per DL within 48 hours or more than 50% from baseline value, known or presumed to have occurred within the prior 7 days, or urine output of less than 0.5 ml per kg for 6 hours. Absence of improvement in serum creatinine or urine output within 24 hours following adequate volume resuscitation, and absence of strong evidence for alternative explanation as primary cause of AKI. So it is also recommended to it is not recommended to to administer albumin systemically for 48 hours because because if you give the albumin, then we cannot make the diagnosis of the HRS. And it is recommended to replacing the historic terms like HRS type 1 and type 2 with the terms such as HRS AKI, HRS AKD, and HRS CKD depending upon the timing and duration of kidney function. So this is the pathophysiology of the AKI. So what happens in the cirrhosis? Cirrhosis, there is a presence of the portal hypertension. And also there is a bacterial translocation. So this bacterial translocation will release the mediators like PAM, pattern-associated molecular proteins, and damage-associated molecular proteins, which will cause systemic inflammation, which will lead to the release of inflammatory cytokines like nitric oxide and reactive oxygen specimen. So, and also because of the portal hypertension, there is a systemic arterial vasodilation. So, because of this release of inflammatory mediators and systemic arterial vasodilation, there is a cardiac dysfunction. Now, because of this cardiac dysfunction, there is a effective circulating volume will be less, and there will be the activation of the RAS system. Now, this RAS system will try to retain the water inside the body, which will produce the ascites as well as hyponatremia. And also, because of this, there will be the reduction in the renal blood flow. This reduction in the renal blood flow will cause the functional changes in the kidney, which will manifest as HRS-AK. If it is causing the structural damage, then it is known as acute tubular injury. If it is both, then it is AKI plus AT. So, as we have seen already in the definition, the HRS is this HRS is divided into HRS AKI, HRS AKD, and HRS CKD. So if there is a features like rise in serum creatinine of more than 3 mg within the past 48 hours, and if the serum creatinine if of more than 50% of known and presumed to have occurred within prior 7 days, and if there is a drop in the urine output of more than 0.5 ml per kg per hour for more than 6 hours. So all these criteria are falling into the category of the AKI. And that means all these are there. That means there is an acute kidney injury. So now, according to the timeline, if it is if it is acute kidney injury, then it is a persist for the less than 7 days. So sometimes there is a resolution of the AKI, but there is a but patients still have the abnormalities in the kidney function and structure that fulfills the criteria for the acute kidney disease. And if it is a lasting for the so when we will label it as acute kidney disease, so all these features are lasting for less than 90 days. If these features are lasting for more than 90 days, then we are labeling it as chronic kidney disease. So pathophysiology. So we'll see in brief the pathophysiology of AKI in cirrhosis. So the degree of liver, kidney, cardiac derangement, this together will concomitant precipitating event and exposure may lead to the variety of clinical phenotypes of AKI. So susceptibility to the AKI follows the development of portal hypertension through increased intrahepatic resistance from liver fibrosis and vasodilatation of splanchnic vascular bed, secondary to the bacterial translocation and systemic inflammation. So this vasodilatation leads to the ineffective central blood volume, in turn lead to activation of sodium and water conservation and vasoconstrictive neurohormonal pathway. So the progression of cirrhosis and portal hypertension leads to further vasodilatation and consequently increase activation of this neurohormonal system, leading to ascites, extreme vasoconstriction, and HRS-AK. So in the early phase of decompensated cirrhosis, the cardiac output increases, but the release of cardiodepressive substance leads to the subclinical changes in myocardium and impairment of cardiovascular reflex, which coupled with the cardiodepression and diastolic dysfunction and is termed as cardiac cirrhotic cardiomyopathy. Secondly, there is also translocation of the bacteria and bacterial product and overt infection, which is associated with release of pathogen-associated molecular pattern, are fundamental in the development of HRS-AKI, particularly in patients with acute or chronic liver failure. So this PAM activate innate host immunity and release of pro-inflammatory cytokines, vasodilator, reactive oxygen species, which may all impair renal function. So, what are the approaches for the prevention of AKI in patients with cirrhosis? So, it is recommended strategies to mitigate the risk of acute kidney injury that include personalized kidney liver health assessment to inform susceptibility to AKI, nephrotoxin stewardship, and liver specific recommendation for anticipated and unanticipated exposure. So it is recommended that 20% to 25% albumin for prevention of ACAR following this large volume paracentesis and in patient with the spontaneous bacterial peritonitis. So the dose and duration of the albumin administration should be guided by patient's hemodynamic and volume status. So it is recommended against the systemic use of albumin in patient with decompensated cirrhosis for prevention of AKI in patient with non-spontaneous bacterial peritonitis infection and solely to maintain serum albumin concentration of more than 3. So many times in ICU, we are seeing it is a reflex action to give the serum albumin if we find the serum albumin is less. But ideally in ICU, there are only three indications for giving albumin. That is if the patient with the spontaneous bacterial peritonitis, if the patient with the ascites where he underwent large volume paracentesis of more than 5 liters, and if we know it is HRS, then only. Otherwise, if the patient is coming with the uh, cirrhosis and if we find the serum creat is raised, then don't start albumin blindly. So in the context of this albumin, there are two trials were published, that is match trial and the answer trial. So in match trial does not show the lack of survival benefit in the match trial. It was because of the few patients are completed 12-month follow-up as they may underwent liver transplantation. But in the answer trial, patients receiving albumin were seen more frequently compared to those in the control group. Thus, observed survival benefit could have resulted from earlier detection and treatment of the complication. Therefore, there is insufficient evidence to recommended long-term outpatient administration of albumin for prevention of AKI in patients with uncomplicated ascites. So we'll see what are the strategies to prevent AKI in patients with cirrhosis. So first is iodinated contrast media exposure. And the preventive intervention is optimize fluid status to maintain euvolemia. There is no clear evidence to guide optimum rate and the duration of infusion of fluids. Hold diuretic only in patient with the hypovolemia. There is no role of N-acetylcysteine and the urine alkalinization with IV bicarbonate solution. Predisposing factor for contrast-induced nephropathy include female sex, presence of ascites, advanced liver disease, presence of infection, and underlying kidney dysfunction. Incidence of contrast-induced nephropathy is very low, and therefore IV contrast studies should not be withheld due to concern regarding AKI, where the information obtained could potentially have important therapeutic implications. Now about volume depletion. So if the person is volume depleted, then we need to give the volume expansion with balanced solution to correct hypovolemia. We need to discontinue laxatives and the diuretics. Then if we have conducted the large volume paracentesis and if we remove the ascites of more than 5 liters, then we need to replace it with the 20 to 25% of albumin solution to prevent post-paracentesis circulatory dysfunction. If the patient is having variceal bleed, then we need to give the PRBC if the drop in the hemoglobin is less than 8. Uh, then we need to administer systemic antibiotic for 5 to 7 days. We need to discontinue diuretic and consideration of the preemptive tips. Then, in case of SPP, systemic administration of albumin with antibiotic, dose and duration of the albumin administration should be titrated daily according to the patient's volume and hemodynamic status, and try to maintain the map of more than 60 to 65 mmHg in setting of septic shock. Then in case of bacterial infection other than spontaneous bacterial peritonitis, volume expansion with crystalloid solution, preferably balanced solution in patient with sepsis-induced hypotension. Caution with the albumin administration to avoid volume overload and pulmonary edema. Then dose of the fluid should be administered according to the patient's volume and hemodynamic status to avoid under and over resuscitation. Then maintain the map of 60 to 65 mmHg in setting of septic shock. Then regarding the nephrotoxic medication, ensure kidney health by lessening the impact of drug-associated AKI event with prevention and optimal management, including assessment of nephrotoxin burden, ensure safe medication use with vigilant surveillance for drug-related event, and avoid over and underdosing of drugs that are eliminated by the kidney. Correct dosing may be challenging as serum creatinine may not be representative of true kidney function. It is recommended checking the serum cystatin C for better estimation of kidney function. Then major abdominal surgery. Monitor for the postoperative ascites. Optimize intravascular fluid status and avoid excessive sodium administration. Avoid NSAID for pain control. Then use of alpha pump. Caution with initial daily volume removed by pump that may be increased progressively. And it is not widely available in many countries. Then what diagnostic tool should be included in workup of patient with cirrhosis and AKI? It is recommended using similar tool for diagnostic workup for AKI and patient with cirrhosis as used in those without cirrhosis. So it is suggested using chronic kidney disease epidemiology collaboration (EGFR) equation without race variance, preferably with the cystatin C for assessment of the kidney function, though the performance at low EGFR and those with the ascites may be suboptimal. In addition to the serum creatinine, we suggest complementary use of functional and damage-related marker to aid intimately detection of acute kidney injury, characterization of the different AKI phenotype, and to guide treatment strategies. The diagnostic evaluation of patients with cirrhosis and AKI include clinical history, assessment of intravascular volume status, and detection of potential precipitate. Point-of-care ultrasonography has been suggested as a tool to assess volume status at bedside. However, it is prone to inter-observer variability and challenging to use in patients with significant ascites. So the examination of urinary sediment is difficult in patients with elevated bilirubin level due to staining of cells and cast. Now, assessment of the kidney function. Diagnosis of AKI may be missed or delayed in patients with cirrhosis given serum creatinine is influenced by reduced muscle mass, increased volume of distribution in setting of fluid overload, and interference with the bilirubin. So serum creatinine may also be falsely low by large volume blood transfusion. Cystatin C allow for earlier diagnosis of AKI in patients with cirrhosis with rising level, often preceding changes in serum creatinine by 48 hours. And it is useful prognostic marker for renal outcome and mortality. So in large prospective study in patients with cirrhosis, the addition of cystatin C to the component of MELD score is superior to the MELD for prediction of overall mortality. In addition, cystatin C provides better estimation of renal function, especially in patients with prolonged kidney critical illness, and it may help in drug dosing and management of nephrotoxic drug. EGFR equations such as MDRD and CKD EPI equation were developed and validated in patients with CKD and are inaccurate for assessment of renal function in patients with AKI as they require serum creatinine to be in the steady state. Now regarding AKI phenotype. Role of biomarkers. The combined use of functional and damage biomarker. Functional biomarker like serum creatinine and cystatin C and damaged biomarker like NGAL and albumin enables more accurate differential diagnosis of etiology. Mechanism of AKI in patient with cirrhosis and potentially enables the identification of AKI subphenotype suitable for specific therapeutic interventions. So, biomarkers may also help to detect those at risk of AKI in whom intervention may limit renal damage. However, in the absence of detectable serum creatinine lines, most data are required to define context-specific threshold for damage-related marker that could act as precise diagnostic criteria for AKI. As further damage and functional biomarker are discovered and qualified, we believed incorporating them into proposed conceptual framework. It is an important step towards improving our understanding of mechanism and pathophysiology of AKI in patients with cirrhosis and refining the determination of prognosis and selecting time points and target for intervention. So various biomarkers have been assessed in patients with cirrhosis. The measurement of fractional excretion of sodium to differentiate ATI acute tubular injury from HRS-AKI had been thought to be unhelpful since fractional excretion of sodium is less than 1 is common in patients with cirrhosis even in the absence of AKI. If using lower threshold of FENA in combination with other biomarker and clinical judgment, the test may have improved specificity in identifying HRS-AKI. NGAL is one of the most promising and widely studied injury biomarker, with the level significantly increasing stepwise manner from HRS-AKI to ATI. So, NGAL value of 220 to 225 Lg per gram creatinine has been shown to distinguish patients from acute tubular injury from other phenotypes with response rate to terlipressin seen in 70% of patients with NGAL level of 220. Combining markers such as urine kidney injury molecule 1, NGAL and cystatin C was better than using one marker alone in identifying HRS-AKI. Whether the target level of NGAL that would differentiate between AKI phenotype or response to terlipressin would be different with new diagnostic criteria for HRS-AKI set forth by this recommendation and that remain to be determined. Now about management. It is recommended to personalize strategy for the management of AKI based on individual's kidney liver health profile and AKI phenotype. It is recommended the combination of physical examination and imaging studies, static and dynamic measurement to guide fluid management and frequent reassessment throughout all phases of treatment to avoid volume overload. It is recommended to use crystalloid, preferably balanced solution, as first-line therapy for patients with AKI requiring fluid resuscitation unless specific indication exists for other fluids. It is recommended to discontinue all the fluids and initiation of diuretic or RRT in patients with AKI who demonstrate signs and symptoms of volume overload. There is insufficient evidence to support routine measurement of intra-abdominal pressure in patients with tense ascites and AKI. It is recommended initiation of RRT should be individualized with consideration of clinical context and anticipated or observed life-threatening AKI-related complications. There is insufficient evidence to recommended tips or extracorporeal liver support for treatment of AKI. Now, what strategies which are specific to the management of the AKI? So, it is recommended initiating vasoconstrictor therapy in combination with the 20 to 25% albumin immediately upon the diagnosis of HRS-AKI. It is recommended that the close monitoring of the volume status during treatment of HRS-AKI. The dose of albumin should be adjusted daily based on patient's volume status and immediate discontinuation of albumin if there is evidence of the volume overload. It is recommended that increasing dose of terlipressin every 24 hours if serum creatinine has not decreased by 25% from the baseline, and increasing dose of norepinephrine every 4 hours if MAP is not increased by more than 10 mmHg of the baseline. It is recommended to discontinue vasoconstrictor for AKI if serum creatinine returns to within zero point 0.3 mg of baseline, a severe adverse reaction develops, if kidney function does not improve after 48 hours on maximum tolerated dose, if there is a need of RRT, and maximum 14 days of therapy. It is recommended to go for liver transplantation in selected patients as definitive treatment of HRS-AKI regardless of response to vasoconstrictor directed therapy. So this is the table which showed the dose, how much dose of vasoconstrictor and what vasoconstrictor we should use. So first vasoconstrictor is the terlipressin that we can use in the dose of 2 to 12 mg per day or IV bolus of 1 to 2 mg every 6 hours. Side effects are ischemic events like cardiac, peripheral, or mesenteric and pulmonary edema. Caution, it should be used with caution in patient with evidence of intravascular volume overload. Then the next vasoconstrictor that we can use is the 0.5 to 3 mg per hour. It is the second line vasoconstrictor if terlipressin is contracted. It requires ICU care and a central line placement. Side effects are cardiac arrhythmias and ischemic events like cardiac ischemia, peripheral and mesenteric ischemia. Then the third line vasoconstrictor is the mydrodrin and octrodrin. That is the can be given in the oral form and subcutaneous. Oral form in the form of in the dose of 7.5 to 15 mg every 8 hours, and subcutaneous form is 100 to 200 microgram every 8. It is considered only if terlipressin is contraindicated or transfer to ICU for norepinephrine infusion is not possible. Midodrine may cause bradycardia. Now, the criteria for discontinuation is if serum creatinine is within 0.3 mg per dl of baseline, if there is no improvement in serum creatinine for 48 to 72 hours with maximum tolerated dose, if there is a serious adverse reaction, if we require the initiation of RRT, if there is a plan for liver transplantation and total duration, the 14 days. Then about the dose titration, terlipressin, as I previously mentioned, terlipressin should be increased by at least 2 mg per day every 24 hours for those on continuous infusion up to maximum of 12 mg per day, and increase from 1 to 2 mg every 6 hours for IV bolus if serum creatinine has not improved by 25%. Norepinephrine dose is increased every 4 hours in the step of 0.5 mg per hour to maximum dose of 3 mg per hour if no increase in MAP of more than 10 mmHg or urine output of 50 ml per hour for 4 hours. Daily 25 to 20 to 25% of albumin, that is 20 to 40 gram per day, is recommended. However, the amount and dose should be adjusted daily based on patient's volume status. Albumin should be withheld if there is a evidence of fluid overload and pulmonary edema. Thank you, guys.